Module 6, Cardiovascular System. This recording will cover Chapter 31, Patients with Vascular Disorders. So here's our recap of the purpose of our vascular system. And remember, vascular means vessel. So we're talking about all of the vessels in our body, arteries, veins, and capillaries. So the purpose of these vessels are to transport blood and to transport waste. And without the system, we would die. So each tissue requires a minimum amount of blood per minute to sustain its metabolic activities and to remove waste. So a minute. So that means that cardiac output, the blood that's pumped out every minute, is very important. So we don't want to have reduced cardiac output. The primary culprits in many vascular disorders is arteriosclerosis and atherosclerosis, which is what we're going to talk about next. So you'll hear the two terms atherosclerosis and arteriosclerosis. So what is the difference? So the word arteriosclerosis, arterio is referring to arteries, sclerosis is like hardening or stiffening. So that is a generic term describing the thickening and hardening of an arterial wall. So aging, natural age-related changes can lead to arteriosclerosis, and this is going to cause stiffness in those vessels and a loss of elasticity. So our vessels should be elastic. They should be able to kind of flex with the blood flow to accommodate different volumes of blood. And if it's not doing that, then we're going to end up with some problems. So there are three possible pathological processes. So this means that we don't know or understand exactly why arteriosclerosis happens. So the three top reasons that they believe is one, medial calcific sclerosis. So this is where there's a lot of calcium deposited in arterial walls. The next is arteriolar sclerosis, which is when you have thickening of the little smaller arterioles. And then the third one, the one we hear so much about, is atherosclerosis, which is plaque. And this is when low-density lipoprotein, or LDL, build up in our artery walls. So we're going to go into a little more depth about atherosclerosis. So atherosclerosis is a slow, complex disease that typically starts in childhood and is progressive. So not many people know that this could potentially be happening as a young child, but for most people it is. And for some people it happens much faster, and for some people it doesn't really cause a problem, even though it starts in childhood. So the pathophys on this, we have vessel damage. Now this isn't completely 100% confirmed or 100% understood, but this is a theory that most textbooks go by. So the idea is that if you have a lot of LDL proteins, and remember those are like transport proteins that transport that lipid, that cholesterol, into the artery wall and into our cells for storage. So if you have a lot of those circulating and then you have some type of vessel damage that attracts our inflammatory response, that vessel damage site is going to also attract lots of LDL proteins, which will eventually lead to atherosclerotic plaque formation. And again, that's going to lead to those hard, thick vessels that don't really accommodate blood flow that well. So the risk factors for atherosclerosis, which are very similar to all of our cardiovascular health risk factors, would be high cholesterol, high triglycerides, high LDL, low HDL, hypertension, diabetes, smoking, family history, obesity, sedentary lifestyle. So of course, we're going to be educating the patient if they have any of these risk factors to hopefully try to either check them, control them, or reverse them if possible. Signs and symptoms. So it's going to depend on which artery has the problem. If it's an artery that feeds the brain, is it an artery that feeds the leg? And the smaller it is, it can turn into a medical emergency. So if it's in the heart, then that can lead to myocardial infarction or sudden cardiac death. If it is a vessel feeding the brain, then we can have a stroke. And if it's a vessel feeding a limb, then that limb can become gangrenous. So treatment is aimed at identifying and controlling risk factors, so prevention. So we want to do the opposite of all of those risk factors, right? So decrease the LDL, give them anti-cholesterol medication, give them anticoagulants, change the diet, tell them to stop smoking, lifestyle changes, exercise, and teaching them of this condition. So surgical management is usually used for irreversible manifestations. So like if they have gangrene, then they will, cut the limb off or try to restore blood flow. Atherosclerosis can lead to lots of other things. It leads to hypertension, coronary artery disease, and peripheral vascular disease, which makes sense. Assessments, we're going to get a good HMP and cardiovascular assessment, blood pressure. We want to check pulses because that's how we know things are moving. We want to auscultate for bruits. That's a swishing sound, which we should not hear because swishing sound means that there's turbulent blood flow and there's something going on in there. We're going to get those labs, including A1C, to see if they have diabetes. And then medications, antihypertensives, and lipid-lowering drugs. All right, so now we're moving on to the silent killer, hypertension. So we did talk about what is involved with blood pressure. That is going to be cardiac output times total peripheral vascular resistance, which is PVR. Cardiac output is stroke volume times heart rate. And then we have our peripheral vascular resistance formula, which is the mean arterial pressure divided by cardiac output. Do you need to know these? No, but just know that everything is tied together. Everything affects one another. So the pathophys on hypertension. So anything that increases cardiac output or increases peripheral vascular resistance or increases heart rate can affect your blood pressure and can lead to hypertension. So some mechanisms in our body that can result in hypertension is if you have a lot of sodium dietary intake. The RAS system. So the RAS system is a very well working machine and sometimes it works against us. Aldosterone, we know that hormone is related to sodium and water balance, and then our sympathetic nervous system. So there are two types of hypertension, essential or primary hypertension, and the other is secondary hypertension. So with essential or primary, we don't know why. There's not a real medical condition that we can find on the patient. Secondary hypertension is when you have high blood pressure and we know the reason why. So risk factors, general risk factors for hypertension are going to be race, gender, and socioeconomic status. And then if you see this little picture here, it shows you the values of when we start to get nervous. So we're going to say 120 over 80 is a normal blood pressure, and you see it increasing. We say stage 1, stage 2. If you have 180 over 120 or more, then we consider that a hypertensive crisis. So this is straight from your textbook. This lists those mechanisms that I just mentioned, and it tells you the reason why it causes hypertension. So you can look over that. So this is your textbook's classification of blood pressure, which is similar to the picture that I just went over. So you can kind of read through those. All right, signs and symptoms of high blood pressure. So typically you're not going to have any until the disease is advanced, which is why it's called the silent killer, because by the time you realize you have it, the damage has already been done to your organs. Headaches, chest pain, vision changes, shortness of breath, renal dysfunction, dizziness, fatigue, and nosebleeds. So all of these things are damage. When you start feeling headaches, that means those vessels in your brain are becoming injured. Chest pain, the vessels in your heart. Vision changes, the vessels in your eye. Shortness of breath, your lungs, kidneys, all of those little vessels are becoming damaged, and now your body is telling you that, hey, there's a problem. So treatment, change lifestyle. So your weight, the diet, decrease or stop drinking alcohol, exercise, and decrease stress. Medications, possibly diuretics and antihypertensives. So how do we diagnose hypertension? So you are going to need at least 2 blood pressure readings on 2 different office visits. So if a patient comes into the doctor's office and their blood pressure is elevated, they are not diagnosed with hypertension. So the person taking the vital signs may say, oh, your blood pressure is very elevated. Maybe they're nervous. Maybe they walked there. Maybe they just went up a flight of stairs. We're not going to take that first blood pressure as fact. They may take the blood pressure again at the end of the visit to see if there's any changes. And if it's still elevated, then they will likely have them come back in a day or two, in a week, to have their blood pressure retaken just to confirm that it is a true high blood pressure. Hypertension complications. So complications are what we were trying to avoid. And since this is considered the silent killer, a lot of times patients are already going to have this by the time they are diagnosed. So these are our target organs. So the heart. So this gives a description on what hypertension does to the heart. Ultimately, the ventricles will eventually dilate. It's going to cause a dilated cardiomyopathy and heart failure. So those are bad. In our kidneys, eventually there's going to be reduced blood flow to the kidneys that can lead to death of kidney cells. So you can go into renal failure. Stroke. The high blood pressure can cause vessel rupture, and that can lead to hemorrhage in the brain, and that is also bad. So these are our target organs: the heart, kidneys, the brain, and I put this little picture here to remind us that all of our arteries and our vessels are also affected by hypertension. Continuing on with hypertension complications. Hypertensive crisis, a phrase you might have read in your patient's charts. So hypertensive crisis is an umbrella term, and it refers to either hypertensive urgency or hypertensive emergency. So hypertensive urgency is related to a very high blood pressure, but there's no obvious acute TOD. So TOD is target organ damage, and our target organs are the heart, brain, and kidneys. In hypertensive emergency, this is where you have a really high blood pressure, but there is evidence of damage to those target organs. An example would be signs of a stroke, and obviously that would be an emergency. So why do some patients have a hypertensive crisis? So if you are an older adult, if you're African American, and you're a male, you are at higher risk for having a hypertensive crisis. Medication interactions or abruptly stopping your treatment is what you're going to most commonly see patients coming into the emergency room where they have hypertension, they have medication they're supposed to be taking, and they stop taking it. And then all of a sudden the heart or the blood pressure just goes crazy high and they go into this crisis. So really important that we teach our patients compliance and the importance of taking their medications as prescribed. Next is peripheral artery disease, or PAD. So the pathophys on this one: obstruction of blood flow through large peripheral arteries cause partial or total occlusion. So we're talking about the peripheries. So we usually think of our legs as having peripheral artery disease, but actually our upper limbs can have it too. And technically, if you have peripheral artery disease, it is very, very likely that your arteries in your whole body have been affected to some degree. Okay, so back to this. So PAD is progressive and it is chronic, so this will only get worse if you don't stop the things that are causing it. And the culprit, the primary reason this happens is from atherosclerosis. So as we know, with atherosclerosis, there is a degree of inflammation. The vessels start to narrow. They have stenosis. There can be thrombus or even emboli associated with it. So it is a combination of all of these things that result in peripheral artery disease. And because atherosclerosis is the main contributor to PAD, then the risk factors for PAD are going to be the same risk factors for atherosclerosis. So we have smoking, hypertension, diabetes, dyslipidemia, sedentary lifestyle, and ineffective stress management. So you may wonder how they have connected stress to peripheral artery disease. So scientists think that chronic stress can lead to endothelial injury. So like the endothelium of the inside of the vessels, when you're stressed out, it kind of activates our immune system and it causes our macrophages to be released, and it promotes, injury on our vessel walls essentially. Also, cortisol hormone can also cause your cholesterol to increase, your triglycerides, your blood sugar, and your blood pressure to increase. So all of those things can contribute to PAD. Clinical manifestations of peripheral artery disease. So a patient may complain or have a subjective concern describing pain when they exercise, meaning maybe they're taking a walk, maybe they're taking a jog, and they start to feel like a cramping, a muscle ache pain in their calf. And this is a classic sign of peripheral artery disease. So they feel this pain and then they stop, they take a break, and then the pain goes away. So that is termed intermittent claudication. So again, intermittent claudication is pain in the calf or muscle cramping, or it feels like a sore, tired muscle, and the pain goes away when they rest. Okay, so intermittent claudication is indicative of peripheral artery disease. And this is not to say that patients don't have pain at rest. This is just a definition of intermittent claudication. They could technically be at home, on their couch for a few hours and still kind of have a cramping pain, which is also an example of a sign or symptom for PAD. We just don't call that intermittent claudication. Okay, so also to note is that PAD can come in less severe forms and then very severe. So it can progress to really severe forms. And remember, this is all because there's ischemia happening at some level. Those arteries are becoming smaller and smaller because of all of that plaque from the atherosclerosis, and the blood is having a hard time getting where it needs to go. When those tissues are deprived of oxygen, it kind of manifests as pain. Okay, so this patient can have just a little bit of pain, or it can be so debilitating that they cannot even get out of bed to walk to the bathroom in the morning. Moving on to diagnosis. So we're going to get a good H&P, and this is going to be like a cardiac focus assessment, all of those assessments that we talked about, especially a vascular assessment, neurovascular, pulses, palpating the extremities, auscultating with your stethoscope for a bruit, and a very good inspection of the legs and feet. So when you look at the skin, there could be hair loss because there's just not enough oxygen-rich blood feeding those little hair follicles that they pretty much just die and fall out. The temperature may be cool, the color may not look so great. Okay, so you're doing your vascular, your circulation assessment. You also want to rule out other causes that could be potentially presenting the same way. Another diagnostic test that could be done is called an ankle brachial index. Now, this typically is not done by the RN, it's done by a tech, and pictured here is one example of how they could do it. So they take the blood pressure on an extremity the regular way, and then they take the blood pressure on the lower leg, like around the ankle. They're going to divide the ankle blood pressure by the brachial blood pressure, and there is going to be a number. So this little chart here tells you what that number represents. So normally we should be between 1 and 1.29. If you have severe PAD, you're going to have a very low number, which is going to be 0 to 0.4. So again, ankle brachial index, ABI, the lower the number, the more severe the PAD. So for peripheral artery disease, the primary goals are going to be to relieve those symptoms that they have because of it, to prevent it from getting worse and, to develop complications, to improve their quality of life, and to make sure that they understand what this is and how they can prevent it from getting worse. So medications, antihypertensives, antiplatelets, and statins. Surgical management, if they have a complete blockage or it's just about going to get blocked, and they can go in with a stent or a couple of other things they can do, but basically they go in and take the clot out. Complications of peripheral artery disease include critical limb ischemia and acute limb ischemia. So this means that there's obstructed blood flow, and if there's no blood flow, there is no oxygen going to that limb. So it can be a foot, it can be the whole leg, it could be a toe. So that tissue will start to die, it'll become ischemic, and it can lead to gangrene and even amputation. So that is the ultimate complication we are trying to avoid. Our assessment. So we want to take bilateral blood pressures because patients can potentially have different artery integrity. We want to take blood pressures on both sides, and we want to take the highest blood pressure of the two. We want to palpate all of the pulses along the leg so that we can get a good idea of blood flow. We want to look at the feet and limbs, and we're looking at color, we're feeling for temperature, and assessing the bilateral muscle tone. So patients who have chronic PAD, they can actually lose muscle. The muscle can atrophy, so that's why we check for muscle tone. And then pain. So whichever side is affected with the PAD, it can be very, very painful. And as we know, we just learned about intermittent claudication. So if they have pain that goes away with rest, then we know that that's a sign of PAD. And then moving on to teaching. So if you remember, when patients have like fluid overload, we want them to raise their leg above the heart to, encourage venous return and circulation. But with PAD, we don't want it to raise up because it's going to be harder for the heart to push that blood to that limb or to that extremity. So we actually want them to keep the affected extremity dependent to facilitate blood flow. So it's the opposite. So having your legs dependent, like kind of hanging down, will kind of help that flow. The gravity will kind of pull the blood to the extremity. We also want to have them inspect their feet daily because of the poor blood flow down to the limb, most distal from the body. Ulcers can develop, so we want to make sure that they're checking that out. They should report any kind of chest discomfort because, again, peripheral artery disease, you're likely to have other vessel issues, and if we want the heart, and we don't want the heart to be forgotten, right? If they have chest pain, that can be something going on with those arteries. And then lifestyle changes. So same thing that we would suggest with atherosclerosis. So limit alcohol, stop smoking, exercise, and all of those other teachings that we went over. Moving on to carotid artery disease. So we're talking about the carotids in our neck. So this is the artery that feeds the brain oxygenated blood. So again, carotid artery disease is a common atherosclerotic vascular disease. So just another vessel we're talking about here. This is going to cause vessel wall thickening and plaque formation, occluding that carotid artery, which will eventually lead to stroke. Risk factors, the same risk factors related to atherosclerosis: smoking, hypertension, diabetes, high cholesterol, sedentary lifestyle, obesity, and ineffective stress management. Signs and symptoms. So you're not going to have any signs and symptoms until you have lack of blood flow to the brain. This is going to result in a stroke or TIA, which is a transient ischemic attack. So a TIA kind of feels like a stroke. The symptoms are a little bit more mild, and then they resolve on their own. So it's like a precursor to a stroke. So if you have a patient that's having a TIA, there's probably going to be a blockage in the near future. So signs and symptoms of a stroke or TIA is going to be sudden weakness, dizziness, a loss of coordination, difficulty talking, facial droop, sudden vision problems, sudden and severe headache. So diagnosing this, you can hear a bruit on the carotid artery. So if you put your stethoscope on the neck, you can hear a bruit. We can do a carotid duplex scan, which is a ultrasound of that vessel, so that you can see in this picture, you can see atherosclerotic plaques there. MRI and a carotid angiography. So angiography, remember, anytime you see that word, it involves an injection of a dye to light up vessels. Medications, so healthy lifestyle changes and management of comorbidities, because you can't reverse atherosclerosis. You can only stop it, hopefully, from progressing and getting worse. So it's all health promotion and those modifiable risk factors. Surgery. So if you do have a completely occluded vessel or nearly occluded vessel, then, and there's still time, there is something called a carotid endarterectomy, which is a CEA, or carotid artery stenting, which is CAS. And this is where they go in surgically and do this intervention. So we want to give them the meds as ordered, same meds: antihypertensives, anti-cholesterol, antiplatelets, manage diabetes if they have it. When they get discharged, make sure they know the signs and symptoms of stroke, and that's a call 911 if they have those. Lifestyle changes and the DASH diet. So DASH is dietary approaches to stop hypertension. Moving on to aortic artery disease. So we're talking about the aorta, and in the picture you can see the aorta starts when it leaves the left side of our heart, and it goes all the way down to our abdominal aorta here, right before it splits into the femoral arteries. So the pathophys of this, and this is an aneurysm. So the middle layer of the artery is weakened, and there is stretching of the inner layer. the artery widens, there's a lot of tension in there, and it gets really thin, and it kind of starts to bulge. So risk factors: family history, being older, male gender, smoking, if you have atherosclerosis, hypertension, high cholesterol, if you already have coronary artery disease, and some genetic predisposition can also lead to aortic artery disease. So this one, you're not going to have any signs and symptoms unless it dissects or ruptures. You may be able to see a palpable pulsatile mass in the abdomen if you have a abdominal aortic aneurysm. So like if the patient's lying flat, you can kind of see below the in the below the xiphoid process in the abdomen, you can see a pulsation. That could be an aneurysm. It may cause chest, back, or flank pain depending on where the aneurysm is when you start to dissect or rupture. And if you have pain, like say you were diagnosed with an aneurysm incidentally, so maybe you had some other imaging done and they're like, oh, you have an aneurysm, did you know that? And they're like, no, I had no idea. And then you start to have pain, that could mean that there was a change in that aneurysm, and that should be investigated further. Diagnosing an aneurysm, we're going to use a CT with IV contrast. That's the gold standard to assess the size and location of either an abdominal or thoracic aneurysm. We can also do a transthoracic echocardiogram, so an ultrasound of the chest, cardiac MRI, and also an ECG or EKG just to rule out MI because some of the signs and symptoms might be similar. Medications are going to be to control hypertension and anti-cholesterol meds or cholesterol lowering medications like statins. So surgical repair. So not everybody is a candidate for surgical repair of an aneurysm. It really just depends on the patient situation. But they could put in a graft, and these are some different things that you may see in practice here in the picture. So complications of an aneurysm include aortic dissection and aneurysm rupture. So aortic dissection, you can see in this picture here. So blood actually enters the artery wall, so it doesn't escape the artery, but it kind of like filters in here and it kind of bubbles on the side. So this is very dangerous and can lead to aneurysm rupture. So aneurysm rupture, like you see in this picture, is definitely a medical emergency. If you have this happen to you and you're not in the hospital and they don't know about it, you're at home, you're outside, you're likely not going to make it because our aorta is high pressure. That's a lot of blood going through there, so you can bleed out internally very, very, very quickly. But if you're in the hospital and this happens and they're already watching it, or maybe you're in surgery already, that's something that they may be able to repair. Now, it doesn't necessarily mean that it's going to rupture like this picture. It could actually also be just a small ooze, like a drip, a small ooze, which is still emergent, but it may not be like this huge, like a balloon popping. Okay, so like we said, aneurysms are usually asymptomatic until rupture or dissection. Only 5 to 10% of patients experience chest, back, or flank pain because of an aneurysm. And then if they do feel that pain, it really just depends on where it's located that you feel any pain at all. Our assessments for aneurysms are going to include vital signs because heart rate and blood pressure can let us know if the patient has hypovolemia and maybe they're hemorrhaging inside. Neurological assessment because we want to ensure good blood flow to the brain. Pain, peripheral pulses, again, we're talking about our aorta, so we're talking about circulation. We also want to gently palpate and auscultate the abdomen, those vessels in the abdomen. So we're going to give our medications, antihypertensives, statins, and also tetracyclines and macrolides. So these medications these classes of medications can inhibit the abdominal aortic aneurysm's progression by reducing infections in that aortic wall. Because remember, the injury to the wall kind of prompts our immune response. So these medications can actually minimize that AAA abdominal aortic aneurysm from getting worse due to that. And then we want to create a calm environment because stress can lower your blood pressure and put less stress on that aneurysm. So teachings, we want to teach the signs and symptoms of an aneurysm and dissection. We want them to be compliant with the plan of care. So that includes taking your meds, stop smoking, exercise, maintain a healthy weight, etc. All of these things in the green box. Next is deep vein thrombosis, or DVT. Now, before we get started, you see this little phrase here, venous thromboembolism, or VTE. You may have heard that phrase at clinical. VTE prophylaxis. So VTE prophylaxis is referring to deep vein thrombosis and pulmonary embolism. So that falls under VTE. So the pathophys on this. So basically, we have a obstruction in a really large vein is what's going on, a blood clot. So Virchow's triad is decreased flow rate of blood, damage to blood vessel wall, and increased tendency to clot. So these three things, if you have them, then you're very high risk for getting a DVT. So decreased flow rate of blood. So our blood should always be moving. You know, our heart pumps, it moves, it's constantly in transit. And once blood stops moving or slows down, then there's high risk that it's going to coagulate and form clots, stasis. We don't want our blood to be standing still. Damage to blood vessel wall. So if you have any type of endothelial injury, so say you had hypertension or high prolonged hyperglycemia, like you have diabetes, that can cause damage to that endothelium of your blood vessels. And then increased tendency to clot for whatever reason, hypercoagulability. If you have these three things, then you're likely very high risk to have a DVT. DVTs can lead to pulmonary embolism. So that's when the blood clot breaks off, travels up the vessels all the way up to the lungs, and then it obstructs blood flow there, which is bad. So risk factors are going to include increased age, active cancer, varicose veins, which are pictured here. They're like dilated, engorged veins. If you've already had a blood clot, if you are pregnant or just gave birth, oral contraceptives or hormone replacement therapy, and immobility like surgery, trauma, if you're in the hospital, long-term care facility, that will all put you at risk for DVT. So here's this box here. It says approximately half of new VTE cases occurred during a hospital stay or within 90 days of being discharged or 90 days of a surgical procedure. So that is pretty high, which is why all hospitals have some type of protocol when a patient is admitted for VTE prophylaxis. And we'll talk about what that includes next. So signs and symptoms of DVT are going to be related to the inflammatory response. So let's think about this big vein in our leg that has become occluded. So that means that there is no blood flow going through and tissues are becoming ischemic from lack of oxygen, right? So that tissue is dying. So essentially that's a wound. If you have cell death, tissue death, that's a wound. So our body is going to activate our inflammatory response. So we're going to get pain, we're going to get swelling, tenderness, discoloration, redness, and warmth, the classic signs of inflammation. The way to diagnosis, we're going to get a history and physical and find out if the patient has any of those risk factors for DVT. Maybe they were on a long airplane ride, maybe they just had surgery, maybe they've been immobile for the last 2 weeks for some reason. We can do a D-dimer. So what is a D-dimer? So when you have a clot in the body, our body is very smart. It knows there's a clot. It's going to try to break it down if we don't need it. So when it's broken down, there's some protein that's produced. Well, D-dimer measures that protein. So if you have a high D-dimer, that means the body is really trying to break down something. So D-dimer is not conclusive. It's just a tool that we use. If the patient has all the other signs and symptoms and the D-dimer is high, then they'll say, yes, you have a DVT. But if you don't have any signs and symptoms and your D-dimer is high, then that's not a definitive diagnosis because the D-dimer can be elevated in other situations unrelated to a blood clot. Compression ultrasound, that's just a type of ultrasound they could also do to visualize the vessels. So if we can prevent a DVT, then that would be great because we already know most of the patients that come into the hospital are already at risk. So let's prevent it before it happens. Ambulation, great to prevent DVT if the patient is able to ambulate. VTE prophylaxis, so this is going to include medications such as heparin, low molecular weight heparin, which is enoxaparin, even warfarin or apixaban. Those are all medications that can be used to decrease the likelihood of DVT. Compression stockings or TED hose, that's very common after surgery. Sequential compression devices or SCDs, those are the sleeves that you wrap around the calves that will squeeze them to simulate like we're walking. So surgical management, so that's rarely used. This includes thrombectomy, balloon angioplasty, or stent placements. Patients can also have something called an IVC filter placed in the vena cava that is like a mesh that will catch blood clots if they make it up that far. Assessments, we're going to do vital signs because we're dealing with blood. We want to make sure we're assessing that extremity. We don't want to lose blood flow. We want to always compare the left to the right. Gentle palpation because we don't want to dislodge the blood clot. We're going to look at our labs and we're going to monitor for signs of bleeding because these patients will be on anticoagulants. So some complications that can result from this is pulmonary embolism. I mentioned that earlier, where that clot breaks off and travels all the way up to the lungs and then obstructs blood flow up there. Post-thrombotic syndrome, this is when the clot has been resolved, but the patient is still experiencing like chronic pain in that area, chronic swelling, even though the clot is like no longer significant. So our nursing interventions, when we can, early ambulation if it's not contraindicated, especially post-surgery. We want to elevate the legs because we want to encourage circulation. Compression stockings, but we don't want to put the sequential compression devices on once the patient has been diagnosed with a DVT. So if you put on SCDs and the patient has history of a blood clot there or has an active blood clot, then that massaging action of the machine can actually dislodge it and then you have it floating around. Then it's an embolism. We want to encourage adequate fluid intake because we don't want the blood to be stagnant. We want it free flowing. We don't want thick, sticky blood. We want free flowing blood. And then we want to make sure that the patient gets the meds that are ordered. Teaching wise, once they have a DVT, then they are more likely to get one in the future if the situation presents itself again. We want to let them know signs and symptoms of bleeding because they'll be on anticoagulants temporarily. Usually temporarily. They should be compliant with regular lab monitoring, especially if they're on warfarin, because that has to be in a therapeutic range. And then safety precautions because they're going to be high risk for bleeding. And just a couple things related to venous insufficiency, some interventions. So patients should elevate their legs for at least 20 minutes, 4 to 5 times a day to promote circulation. If they're in bed, they should raise the legs above the heart, again, to promote venous return. Avoid crossing legs, and compression stockings should be worn and put on when the swelling is at a minimum. Okay, and that concludes this chapter.